Okay, so I was asked to talk a little bit about living with atypical HUS. I think it's important that you know I'm not per se Dr. Licht. I'm not an atypical HUS expert. I ended up learning a lot about atypical HUS when Tony Vernon came into my life because I'm her physician. So I guess I am now maybe a little bit of an atypical HUS expert. But I picked one topic to talk to you about because it gives an example about what it is like to live with HUS. Like something so simple as a pregnancy that we all take for granted can be a catastrophic thing for somebody if you have this genetic predisposition. So I thought pregnancy was a really nice illustration, and I know there's men in the room who have atypical HUS, but you may have daughters and you may have other family members who potentially could be affected by this disease. So it's an example of how just something that is such a simple, what we would consider a very basic human right is having a child, how it can be affected by a disease. So I'm a pregnancy and kidney disease expert as opposed to an atypical HUS expert. I run a very, very large pregnancy and kidney disease clinic in Toronto. I actually think my clinic's probably the only one of its kind in North America because it's a collaborative clinic where I have a high-risk obstetrician and me as a nephrologist, and I counsel patients about their risks of pregnancy. And over the years, I've counseled well in excess of 1,000 patients, and out of those 1,000, about 65% of them get pregnant. So overall, there's about 50 new pregnancies coming through my door every year. And I can actually remember and put a face to everybody who's had atypical HUS because it's quite rare. So I can count them sort of on my hand, and there's not one of them that I have forgotten. I don't see any of them here, but I have taken care of the ones who are at risk for atypical HUS in pregnancy. And there's two areas where I spend most of my time. One is, what is the risk that you're going to flare? Because I have women who've come to me with genetic defects known, with family histories that are known, and now they're planning their families and they want to know, what risk might there be for me to have a flare of my typical HUS during pregnancy? And then I probably would be the one you would be calling to the bedside, and I've come to the bedside at Mount Sinai and at UHN, and I've been consulted at many hospitals from across Canada to say, what do you think we're dealing with? Because there's mimickers of atypical HUS. It's TTP, which is much more common, and then very, very commonly is preeclampsia, which can look very much like atypical HUS. So I'm often called to the bedside to try to manage that. So those are the two areas in what I do that would apply to atypical HUS. You're not the only ones who flare during pregnancy. Lupus flares, other diseases flare, but we're only going to talk about the microangiopathic hemolytic anemias here, not really TTP. We're all talking today about atypical HUS and what could happen in a pregnancy. Your complement system, I'm not going to go into great detail. Dr. Licht did this for you, but your complement system was meant to protect you. It was meant to take the usual bacteria that come into your world, to take any debris that comes into your world, break it down and protect you. It's your innate immune system. And there's three pathways, which I'm sure you all know more about even than I do. And it's this alternate pathway where C3 convertase can be spontaneously going off on its own. And there we have all these mechanisms to inhibit this one area of the alternate complement pathway. And now we know that there's multiple reasons why we could lose this ability to keep this regulated and keep it under control. And this is just a list of all the various mutations that could prevent inhibition of this pathway, mutations that can stimulate this pathway, and then there's also autoantibodies that we find as well that can be there during parts of your life to really prevent this pathway from being regulated. And when it's taking off on its own, it's clotting off little tiny vessels, and it usually affects your kidneys, but it could affect your brain, and there's people with pancreatitis, and there's all kinds of different ways that this process may affect you. But what we're starting to understand and what makes atypical HUS so hard, like one of the questions, Tony, am I allowed to speak of you? You all know Tony very well, but Tony's got 3 beautiful daughters, and she never had a flare of atypical HUS. Actually, it's 3 daughters, and then you've got the son, right? Yeah. 2 and 2. So that's a lot of pregnancies, and yet there was no flare. So what we're starting to understand that maybe you have a risk, and there's then a variety of triggers, and these triggers have to add up in some way when you're in a very vulnerable state in order to actually cross this barrier and give you TMA. It doesn't happen every single time. And we're starting to understand that some of these triggers are the CNIs, like the drugs you would get if you had a kidney transplant, and even the stress of the transplant itself can trigger atypical HUS. other toxins and infections, and of course pregnancy. And somehow these triggers can add to these various risk alleles, and at some point in your life take you over the top, and then you begin to have TMA. There's various severities of it that we now understand. There's triggers. It may be mild. You may not have a bad episode. It could be very severe. And now there's a drug with C5 inhibition that can start to bring that back down. And here is how pregnancy plays into it. Again, it takes some combination here, and then that results into giving an actual episode of TMA. So I've spent a lot of time trying to figure out how often this might occur, because this is my job, is to counsel young women who come to me who may be at risk for this. And to be honest with you, there's not a whole lot of data out there to guide us. There's a lot of case reports here and there of a woman who had pregnancy and then she got a bad atypical aHUS. Often of them are written in a retrospective lens where the outcome wasn't good and how they had such difficulties differentiating them from other common causes in pregnancy. So the biggest series and the best series out there is really from France. And in France, they have a registry of atypical aHUS, so I'm sure you're all aware of that. And they published a series of 21 pregnancies. So about 20% of these atypical people in the registry with women with atypical aHUS, pregnancy was their trigger. So in 80%, it wasn't. And maybe that's why Tony had all these beautiful children before getting atypical aHUS. And interestingly enough, it was commonly presented in the second pregnancy. And that speaks again to these layering of risk and environment and triggers till you finally get to the point where you actually develop atypical aHUS. And in fact, 74% of the ones with documented complement abnormalities had at least one pregnancy before they developed their atypical aHUS. So they maybe got away with it in their first pregnancy, and then they didn't get away with it in their second or their third or their fourth pregnancy. And this group here is a little bit interesting. These ones that had it in their first pregnancy, 4 out of the 7 were the CFH mutation. So we don't know. Maybe there are certain mutations that are worse than others, and we'll find that out in time. When do people with atypical aHUS actually flare in pregnancy? They actually flare right around the time of delivery. The delivery is when you deliver the placenta. And we know that the placenta comes with a bit of debris, and your complement system is there to help you clean up that debris, and then that triggers this complement cascade about the time of delivery of the placenta, and that's what helps physicians differentiate it at least somewhat from TTP, which could happen at any point in the pregnancy. Atypical aHUS is much more commonly postpartum and around the time of delivery in 79% of patients. And unfortunately, so far at least with what's published, and you have to remember, this was all published when people just had access to Plex. There are not a lot of publications with access to eculizumab, but with there's only access to Plex, the outcomes for mom when it flared during a pregnancy were really very poor. And in fact, 62% of them reached end-stage renal disease by 1 month. Follow-up was about 6 months, and by then 76% of them were on dialysis. And the majority of them absolutely did receive Plex. So it's inadequate to prevent this really aggressive presentation that comes with pregnancy. Babies' outcomes, though, were not terrible. And if you looked at the people with genetic mutations, fetal loss was a little bit higher than the general population at 4.8%. The general population, the risk of preeclampsia is about 5%. So a little bit higher if you have a genetic complement abnormality, but overall babies tend to do quite well. And look again here, uneventful pregnancy in people with known complement genetic disorders is 75%, right? So it's not going to necessarily affect your children, for example, even if they have these genetic predispositions. 75%, at least in the pregnancies that they looked at, didn't get atypical aHUS. So that's hopeful, and that's good to know. In terms of which mutations are worse, the only one that I mentioned that seems to be coming out is the CFH. That was 20%, but it was happening sort of in all of them. People with more than one mutation, it was a 60% chance of actually having an atypical aHUS episode in pregnancy. And again, those with the first pregnancy, 4 to the 7 with them were the CFH mutation. So when I get these women in my clinic, or the daughters of these women in my clinic, or somebody who's at risk genetically for getting atypical aHUS, even if you have the gene, the chances of it happening in a pregnancy is probably about 20 25%. So in other words, it doesn't have to happen. You should be more worried on the second than the first pregnancy because it's more likely in the second than in the first pregnancy. And unfortunately, though, the disease is aggressive. And I'm not sure there's enough information to say for sure this one mutation is a particular issue, but it seemed to from a small bunch of studies. And now we'll just have to look at more registries and get better understanding as time goes on. So the next time I'm going to be called as a pregnancy expert, I'm going to be called to try to diagnose it, because this could be your first presentation. I don't know how many of you was pregnancy the first presentation for anybody in the room? No? Well, that's good. But if it was, they might have called me. So essentially, if pregnancy is your first presentation, it's not that easy for clinicians to diagnose it. The company was right in saying this is a rare disease, and sometimes it's not commonly known everywhere that this is something that could be happening. And it's so rare. This is a study that we just did, and I won't go through great detail of it, but we looked at all 1.9 million pregnancies in Ontario over the last 15 years, and people that had a severe enough presentation of acute kidney injury to need dialysis was very rare, 1 in 10,000. And within that 1 in 10,000 was buried the atypical aHUS patients. So even rarer than that, which makes it difficult to diagnose for physicians. And there's a lot of reasons that you could get kidney failure in pregnancy. And of course, we're talking only about those of the TMAs, which would be TTP or atypical aHUS. And there's 3 major differentials in pregnancy that if you did a kidney biopsy would look the same. Preeclampsia is very common. Preeclampsia is anybody who has a poor placenta, they get hypertension, proteinuria. It's 3 to 7% of all pregnancies, so it's common. TTP would look the same at the level of the kidney, and atypical aHUS would look the same. So this is the dilemma that a physician's going to have to be doing at the bedside. They're going to have to make sure this is not preeclampsia, which is a disease of the placenta, not TTP, which is also predisposed in pregnancy, because Adams 13, which is necessary to break down those large von Willebrand moieties, goes down naturally as part of the hormonal changes in pregnancy. So again, patients at risk will present in pregnancy with TTP, and then of course there's atypical aHUS. And it's critical because the treatment is completely different. You need to zone in on what's happening very, very quickly because the treatment is going to be different. Preeclampsia, it is cured by delivering the placenta, okay? It's a placental disease, that's how you cure preeclampsia. TTP requires PLEX. Atypical aHUS, certainly there's some response to PLEX. Many of the people in this room receive PLEX, but it's an incomplete response and perhaps transient and not as good as you'd like it to be. But now eculizumab may be something that, as long as the diagnosis is made very quickly, that would be an option to treat these women. Right now, there's only case reports of using eculizumab in pregnancy. Most of the data comes from PNH, and it looks to be safe enough. It does not appear to cross the placenta. It's not been found in breast milk so far. And there's only been 1 case report that I can find of a woman who was treated from 26 weeks onward, and overall she did quite well in that pregnancy, delivering at 38 weeks with a very good-sized baby. So in summary, patients need to be aware of their potential risks entering a pregnancy, because if you show up in an obstetrical hospital where they're not very, astute or very, used to this, you would have to help educate them that this could be a flare of atypical aHUS. Our clinicians do need to be educated, and we are working with our hematologists and our high-risk obstetricians to realize that if these women were brought into the high-risk centers at least, and we can pick up atypical aHUS. The members within our group in Toronto are definitely able to diagnose this condition. And of course, if we have availability for eculizumab, this will also change the safety and the potential for childbearing, because there are women who, after we go over the risks, they choose not to maybe have a second child because they're worried about staying healthy for their first child. But this would give us more peace of mind, and we may be able to progress on a pregnancy if we had access. And that's it. I'm happy to answer any questions, but as you can tell, I'm probably the women's health expert, not the atypical aHUS expert. Yeah.
With transplant, the doctors are using prophylactic treatment for going through the treatment, going through with the transplant to prevent an occurrence. So,
Yeah.
for example, if you have had an episode of atypical aHUS, would there be any consideration of using eculizumab like before delivery, for example, if that is one of the reasons that it could flare up?
It could, yeah. It hasn't been reported anywhere where it's being used prophylactically for delivery. Certainly, I think if there was somebody at very high risk, if, for example, you already had a transplant and now you're having a child and certain mutations, that's something that could be considered being used prophylactically in the same way it's being used for transplant. I think right now it doesn't necessarily happen 75% of the time, so it would be about a little bit about choosing which patients that might be most appropriate for. But that's not an unrational thought. It's something that could be considered, especially if you had somebody who you felt was particularly high risk. Perhaps they got it in their first pregnancy. Perhaps they had a transplant. You know, when stakes become very high, that might be something that you would want to consider. There are places, there are people, I know there's more babies being delivered on eculizumab because they email me. They're just not in the literature and they're not published as yet. So we don't have that cumulative knowledge that's sort of out there. But and that being said, I don't know of anybody using it prophylactically.
We have a son who has atypical aHUS, and we haven't been able to find it in our very large extended Italian family anywhere. So we understand that maybe he's the first to present, or maybe we just didn't know what that person.
Yeah, yeah.
He's always wanted to be a dad, and I guess my concern as a mom is, you know, is that a good idea? Can he have children?
Well, he doesn't have to carry the baby, so you're very, very lucky. What he, you know, his genetics would determine what he could potentially pass on, right? But again, we know that, you know, even people carrying the gene, there's many of them that never their entire lives, you know, develop, you know, atypical aHUS. You know, hopefully as, you know, we get larger registries, we have a better understanding of which mutations are passed on that maybe have more penetrance. That'll inform people's decisions, you know, or maybe we'll have a treatment that even if you did pass it on, there'd be options for your child. But from his perspective, it's more the risk for the young woman who's carrying it, who has it. So it's more from his perspective a genetic assessment.